Hello to our friends joining us via recording. We are reviewing for exam number 4, our last regular lecture exam of the semester. That exam is actually open now on Wednesday. It's going to be open through Friday night at 11:59. So make sure you make a plan sometime between now and Friday to get that exam taken. To help us review these topics, we bounced around and looked at several different things from throughout this unit. The first thing, or one of the first things that we talked about in this unit, was the kind of neurons that live in different places in the spinal cord. So when we talk about the type of neurons that live in different places in the spinal cord, we need to know their particular functions. My first statement here is talking about neurons that are found in the ventral horn of the spinal cord. Help me out in the chat. When we talk about the ventral horn of the spinal cord, my neurons who live here, what kind of neurons are these? The ones that live in the ventral horn. Okay, so Nicole's got the first word of their name, somatic, and we're chiming in, Christina and a couple others chiming in with my second word in their name, somatic motor neurons. Somatic motor neurons. When we talk about somatic motor neurons, these are the type of neurons, since they're motor, they're going to make movement happen. When we talk about somatic motor neurons, what kind of muscle tissue do somatic motor neurons activate? Somatic motor neurons. Yes, somatic motor neurons activate skeletal muscle tissue. Skeletal muscle tissue. In the ventral horn, we've got these somatic motor neurons. Their job is to control skeletal muscle tissue. So, as written, if we had this statement, damage to the ventral horn neurons, so my somatic motor neurons, that would impact our skeletal muscle tissue. It would not impact our heart rate, because our heart rate is something that's based on the contraction of cardiac muscle tissue. When we talk about heart rate, that beating is caused by cardiac muscle contracting. So let me make a note up here. Cardiac muscle. Cardiac muscle is not controlled by somatic motor neurons. Which kind of neurons control cardiac muscle? What's their name if they control cardiac muscle? Yeah, the neurons that control cardiac muscle are neurons that are called visceral motor neurons. Visceral motor neurons control cardiac muscle tissue, and visceral motor neurons, a couple of us have already told me, tell me again, which horn do visceral motor neurons live in? Yeah, those are the neurons that live in the lateral horn, Okay, so this first statement here, I told you before we went into group work, there were 2 ways to fix it. The first way to fix it, if we want to stick with the ventral horn, the front horn of the spinal cord, we would say that if I damage the ventral horn neurons, that's going to give me problems with skeletal muscle tissue. So I'm not going to be able to move my hands, move my feet, move parts of my body. That's what skeletal muscle does. If I damage the ventral horn, skeletal muscle has problems. If I want to talk about which horn I could damage that would give me trouble with my heart rate, the horn that's going to give me trouble with my heart rate is if I damage the lateral horn, where the motor neurons that control cardiac muscle or smooth muscle, where those ones live. So when you're reviewing the types of neurons that live in each horn of the spinal cord, we want to know not only what kind of neuron they are and kind of like what they control, but also what might happen if they stopped working. And I'm pretty sure we did a little practice with this, or we at least went through and worked on those statements together that are in your lesson outline. So think about what they do and what might happen if they stopped doing their job. When we talk about the disease called shingles, shingles is a really painful skin disorder. There were some buzzwords about shingles, and I heard several of us talking about them. When you think about shingles, what are some of the important ideas that you all think about when you hear shingles? Let's make a list here of just general information about shingles. What do we know about shingles? Okay, so shingles is an issue with sensory neurons. Sensory neurons, absolutely. When we talk about shingles, it's something that affects particular dermatomes. So we have a rash on one dermatome. Remember that a dermatome is the skin that a particular spinal nerve collects information from. So a dermatome, skin that one spinal nerve collects info from. Yeah, so I'm seeing some notes here about the fact that the virus that causes shingles goes dormant and then it reactivates to give us our rash. What was the, yeah, okay, so I think I saw it in my notes, but I'll see if I can get more than one of us to say it. What virus, what other disease does this virus cause that shingles is the reactivation of? Yep, so chickenpox virus. Chickenpox virus goes dormant, and when it's hiding, when it goes dormant, like several of us have said in the chat, we're in that place called the dorsal root ganglion. The dorsal root ganglion. So when we talk about shingles, this is caused by the virus. Well, so its technical name is varicella. Ariel asked if it is its technical name. No, I mainly put chickenpox virus here to remind us the other disease that causes it is chickenpox. So varicella virus, that's a good clarification. The varicella virus, the one that causes chickenpox. You get chickenpox, varicella virus goes dormant. It's chilling out, it's hiding inside the dorsal root ganglion somewhere in your body. When it reactivates, you get this shingles rash. And the characteristic of a shingles rash is that it's going to affect one dermatome on your body. So dermatomes are those places, if you remember that picture that had a map of dermatomes, remember that dermatomes are the special sliver of skin. You have lots of spinal nerves, and each of those spinal nerves collects sensory information from particular places on the skin. So when you look at your torso, we have horizontal dermatomes, where it's basically a ring of skin from front to back that we send all of the sensory information back through one particular spinal nerve. Or when we're looking at the arms or the legs, those dermatomes go a little bit vertical. They're kind of going up and down because that's the skin that each of those spinal nerves collects information from. So whatever spinal nerve I was chilling out in the dorsal root ganglion of, if I'm varicella and I reactivate, I'm going to travel down my sensory neuron that had its cell body in the dorsal root ganglion. I'm going to travel down that sensory neuron, basically go out to its dendrites and explode. I explode out there, that causes the rash that you see on the skin, and that makes it really painful. So shingles, a very painful condition. Literally, we're killing sensory neurons, or we're exploding sensory neurons when this virus replicates. And it goes out to that skin where that neuron was collecting information from. So when I look at my statement here about shingles, when we look at our statement about shingles, it's talking about neurons in the lateral horn of the spinal cord. What did we say about the neurons here What kind of neurons live in the lateral horn of the spinal cord? What kind of neurons were out there? Yeah, the ones in the lateral horn are what we call the visceral motor neurons. The visceral motor neurons. When we talk about visceral motor neurons, that's not sensory neurons, right? Shingles is not a problem with visceral motor neurons. Gloria asked the clarifying question what visceral means. Visceral means organs. So the kind of motor neurons that control the muscle that's in organs, smooth muscle and cardiac muscle. My organ muscles are in the lateral horn. Shingles is not a problem with motor neurons at all. It's a problem with sensory neurons. But remember, this was a question we've said multiple times. Sensory neurons do not live in the spinal cord. Remember, sensory neurons do not live in the spinal cord. Sensory neurons live out here. Here, let's do a really terrible drawing, really fast. Terrible drawing of the spinal cord. Okay, here's the spinal cord. Here is my gray horn. Look at that beauty right there. We're going to draw ourselves a dorsal root and draw ourselves a ventral root. Okay, here's my really awesome spinal cord right here. When we talk about the lateral horn, those ones that control cardiac muscle and smooth muscle, that's out here. When we talk about the ventral horn with skeletal muscle, that's up here. What kind of neurons live in the dorsal horn? Who lives back here? Yeah, so we haven't talked a lot about these ones during our class today, but these ones right here that live in the dorsal horn, those are interneurons. Those are processing neurons. So an important note for us to remember, dorsal horn equals interneurons. The type of neurons that live here in the dorsal horn, these are my processing neurons. When I ask you where a sensory neuron lives, a sensory neuron lives out here in the dorsal root ganglion, the bump on the back side of what comes into the spinal cord. So shingles is actually not a problem with the spinal cord at all. It's not a problem with a horn at all. Shingles is a problem with the neurons that are in the dorsal root ganglion. When those neurons have the varicella virus inside of them, and that virus gets reactivated, or it turns itself back on and starts to divide or replicate, make copies of itself, it's going to explode out of those sensory neurons and give you the skin rash that you see in shingles. So a review for us of the horns and a review of shingles. Any questions about either of those things before we move on? Okay, so let's move on. Next, I told you that I made up a completely bogus tract in the spinal cord. So this is not real. If you do a Google search, it does not exist. But I'm asking you to make some predictions about it based on its name, because that's the big thing. One of the big things we're doing with tracts is predicting things based on their names. So let's go through and see if we can answer these prediction questions based on the name of this tract. First thing for us to remind ourselves, when we talk about tracts in general, are tracts something we find in the gray matter or the white matter of the spinal cord? Where do I find tracts? Yeah, tracts are always found in the white matter of the spinal cord. Remember that the white matter has a lot of myelin, and myelin makes messages go quickly. The job of a tract is to send a message quickly, send it up or send it down really fast. So we always find tracts in the white matter of the spinal cord. This particular tract is called the spinoparietal tract. So based on its name, spinoparietal, would we say that this one is ascending or descending? What kind of tract would spinoparietal? Yeah, spinoparietal is going to be an ascending tract. And I know that because I'm going to break apart its name here to answer my where it starts and where it ends questions. The first part of its name, spino, is telling me about what? What's the spino part of its name? Where are we starting? Yeah, we're starting in the spinal cord. And the second part of its name, I'm not even going to say it because that's just going to give it away. The second part of its name, yep, absolutely. So the second part of its name tells me that it's going to end in the parietal lobe. It ends in the parietal lobe. If you were to think about, use your basic anatomy from lab, the spinal cord is below the brain, below the parietal lobe, below any part of the brain. The thalamus, the cerebellum, the spinal cord is always, yeah, as Gloria said, inferior to anything brain related. So my wink wink nudge nudge for you, if we start the name of a tract with spino, it's always an ascending tract. Every place that I send information is superior to the spinal cord. So if we start with spino, it's always an ascending tract. If I end with spino, if we end up in the spinal cord, that would always be a descending tract. So if we have something like our example in class, we had that thing called the corticospinal tract. Notice how this time the spinal was at the end of that tract. If spinal is at the end of the name of a tract, that's going to be a descending tract. The information is going down. So really, the only thing you have to look for when you're looking at the name of a new tract, we want to look for the location of spinal. If you see it at the beginning, it's an ascending tract. If I see it at the end, it's a descending tract. Look for the position of the word spinal in its name, and that's going to tell you which direction information goes. All right, let's go back to the one we're working on here, the spinoparietal tract. Because we said this is an ascending tract, are ascending tracts sensory or motor? What kind of tract is an ascending tract? Yeah, ascending tracts are always sensory tracts. I'm only ever going to send sensory information up to the brain. When we talk about ascending tracts or sensory tracts, how many neurons do ascending or sensory tracts usually have? Yeah, pretty much all of them. The number I want you to know for most of them is going to be 3. Whenever you see that it's an ascending tract, I want you to be thinking 3 neurons. We did talk about that exception, right? Remember we talked about the spinocerebellar tract. When we talked about the spinocerebellar tract, that one was different because that had how many? How many neurons were in that particular tract? Yeah, that one only had 2. But remember how we said that this is kind of the exception that proves the rule? Everybody else that is an ascending tract is going to have 3 neurons. The reason spinocerebellar doesn't have a 3rd neuron, yeah, is because of where it ends, right? It ends in the cerebellum. When we have 3 neurons that are in a typical ascending tract, where does that 3rd neuron, the one called the 3rd order neuron, where does the 3rd order neuron start? Yeah, the third order neuron starts in the thalamus. Starts in the thalamus. This particular tract never makes it to the thalamus. Because it doesn't make it to the thalamus, I'm not going to have a third order neuron. I am going to have the first order neuron, and I am going to have a second order neuron. Remember, these are my names of the neurons in an ascending tract or in a sensory tract. Every sensory tract, except our one exception here, every sensory tract has 3. If we were doing a motor tract, like corticospinal, if we're doing a motor tract, how many neurons do motor tracts have, or descending? Yeah, descending are going to have 2 neurons. What's the name of those 2 neurons in a descending tract? Yeah, exactly. I'm going to have an upper motor neuron, and I'm going to have a lower motor neuron. If I have a descending tract, upper motor neurons that start in the brain or possibly start in the cerebellum, for example, if we're talking about balance, and my lower motor neuron is what's found in the spinal cord let's tie it back into what we were talking about before. The lower motor neuron is going to be found in the ventral horn of the spinal cord, where we had those motor neurons that go out to do skeletal muscle. So in a descending motor pathway, we're going to have 2 neurons, the upper motor neuron in the brain or the brainstem, and the lower motor neuron that's in the spinal cord and goes out to skeletal muscle. Do we have any questions about tracts? I know I saw earlier someone had asked the question about gray matter being the location of reflexes. That is correct, yes. And we'll swing back to reflexes once we review this stuff. But yeah, the gray matter of the spinal cord, that is the location where we would do reflexes. Otherwise, we're sending information up or down. That's the job of the white matter. All right, well, let's move into special senses then. I asked you to outline the process of hearing because we want to make sure we know what order these things go in. So let's work our way through our flow chart that shows us the process of hearing. We start with the sound waves that are in your environment. Remember from lab that the outside part of your ear that you can see is called the auricle. It's acting like a funnel. It collects sound waves and funnels them into the little tube. Remember that meatus was kind of like a tube or a passageway. So we collect sound waves with the auricle. We funnel them into a thing called the external acoustic meatus, the hearing hole, essentially. At the end of the external acoustic meatus, those sound waves are going to bump into something. What's the something that divides the external ear from the middle ear? What do those sound waves bump into? Yeah, we're bumping into the thing. Let me change colors here. We're bumping into the thing called the tympanic membrane. Yeah, or like Tierney mentioned in easy person words, that's the eardrum, the tympanic membrane. Oh, I like it. Christina found a drum emoji. That's perfect. Beating on that tympanic membrane, that drum, we've got the 3 ossicles. So let's do those ossicles in order together. The first one is the one that's like your drumstick, right? So the first one is like a mallet. It's called the malleus. When the malleus starts vibrating, it bumps into its neighbor. Its neighbor is called the incus. And when the incus vibrates, it bumps into its neighbor called the stapes. You remember from lab, the stapes one kind of looked like a stirrup, like you'd have on a saddle of a horse. The flat part of the stapes is up right next to the structure that divides the middle ear from the internal ear. What's the structure that sound waves go from the stapes into the internal ear? They're going to pass through, they're going to pass through the oval window to get to the internal ear. Yeah, there was a good question in the chat. The question asked, what kind of fluid do we have in the middle ear? And the correct answer that Jacqueline put in the chat for us, there's not supposed to be fluid in the middle ear. The middle ear is supposed to have air. Yeah, so if we have fluid in the middle ear, we probably either have a current ear infection or we've just gotten over an ear infection. If you remember from lab, there was the thing called the pharyngotympanic tube. That little tube that went down helped you to equalize pressure in the ear. Sometimes bacteria like to climb up that pharyngotympanic tube to get into the middle ear. And if they divide in there and they're growing in there, making a bunch of pus, essentially, that's what an ear infection is. So technical name for an ear infection, it's called Otitis Media. That means inflammation of the middle ear. Middle ear infection, Otitis Media. When you have an ear infection, there's kind of like pussy stuff behind the tympanic membrane. When you've just gotten over an ear infection, there still might be some fluid back there while it's clearing up. Normally, though, it's supposed to be an air-filled space. There's not supposed to be fluid in the middle ear. Nicole asked about swimmer's ear. I think swimmer's ear actually is an issue with water that won't leave the external acoustic meatus. So water that's on the outside, because it wouldn't make sense for water to be in the middle ear unless your tympanic membrane has a hole, because the tympanic membrane seals that space off. I suspect that swimmer's ear is an issue where fluid will not leave that outside hearing hole, swimmer's ear. Okay, so we should have air in the external acoustic meatus. We should have air in the middle ear. Once we get into the internal ear, once we're on the other side of the oval window, now we're starting to move in fluid. So on the other side of the oval window, I have a fluid-filled tube. What's the name of the tube that's on the other side of the oval window? Yeah, it's called scala vestibuli. Scala vestibuli. This is the first tube that I send my sound waves into in the internal ear. Scala vestibuli is filled with a fluid called perilymph fluid. And if you remember from our discussion of hearing, perilymph fluid doesn't actually help you hear. Perilymph fluid just moves sound waves. The type of fluid that actually helps you to hear is endolymph fluid. So endolymph fluid is inside the tube where you actually hear in. What's the name of the tube where we actually do hearing? Yeah, we actually do hearing in that middle tube called the cochlear duct. The cochlear duct. That's the tube that I actually hear inside of. Remember that the bottom of the cochlear duct is something called the basilar membrane. It's the basement membrane. It's sitting underneath the type of cells that actually help us to hear. What kind of cells help us to hear? Yeah, we better make sure we know these. I know we do. The type of cells that help us with hearing, we must know. Their names are hair cells. When we talk about hair cells, they get their name because they have all those hairs that are sticking up. when the basilar membrane underneath them starts bouncing, the hair cells start bouncing too, but they bounce into or they bump into the tectorial membrane. Hey, when they bump into the tectorial membrane, what kind of channels get opened when they bump into the tectorial membrane? What kind of channels do hair cells have? Yeah, exactly. Hair cells have mechanically gated, specifically it's potassium channels. I'm mainly interested in you knowing the fact that it's mechanically gated channels that hair cells have on them. The reason that potassium is important, or it's worth noting, is because remember, endolymph fluid has a ton of potassium in it. So I've got mechanically gated potassium channels. Remember, mechanically gated means I've got to push them open. When I push them open, potassium rushes inside, and that's going to help me depolarize my cell. So that's going to help me to hear a sound. And we'll talk in just a moment about what I do when I'm hearing sounds. But hair cells aside, they've gone through their process, they've heard a sound. Now we want to get rid of that sound. So I'm going to transfer that sound from the cochlear duct into which tube? What's the name of my tube where sounds go to die? Or my recycling tube? Yep, the tube that I send my sounds to when I'm done hearing them, scala tympani, scala tympani. This tube is filled with the fluid, again, that I don't use to hear, perilymph fluid. I send the sound waves through the perilymph fluid. I send them all the way to a structure that spits them back out into the middle ear. What's the name of the membrane that they bump into before they're completely gone? Yeah, the last thing they bump into, that's called the round window. The round window is the end of the internal ear. It's where I go back into the middle ear, but because there's nothing there to catch those sound waves, they just dissipate. I don't hear them anymore. So once my sounds go through the round window, I can't hear them any longer. I'm done processing those sound waves. Any questions about this? Okay. Getting a lot of positive messages in the chat, so we'll call it good. Let's look at then, we briefly talked about the hair cells when we push open their mechanically gated channels. Let's talk about how that relates to the number of neurotransmitters then that we send. Remember that when we were talking about not only the processes of hearing, but also our two kinds of balance, our two kinds of equilibrium, your body's ability to know that we're hearing something, or that we're bending forward, or that we're spinning, it all comes down to the number of neurotransmitters, or the rate that my neurotransmitters are being released at. So we're going to have, with each of these processes, we're going to have conditions where we spit out a lot of neurotransmitters, or maybe we could say that we spit them out really quickly. So we're sending a lot of messages fast. We're going to have times where we send out a few neurotransmitters, or the way that we kind of talked about it in class was slow and steady, right? Where we got a slow and steady ping of information. And then we're going to have times where we have no neurotransmitters. So we're not sending any messages. There's no pings going at all. When we talk about the process of hearing, we can relate that to the number of neurotransmitters. So less the rates, more about the number of neurotransmitters. When you're hearing something, how many neurotransmitters are your hair cells spitting out? When we're actually hearing a sound, how many neurotransmitters? Yeah, so when you're actually hearing a sound, we've got a lot of neurotransmitters that are being spit out. Here's kind of a wink, wink, nudge, nudge reminder. We talked about the mechanically gated potassium channels that bring in a bunch of potassium. That makes the membrane really positive. And just like when we were talking about regular neurons, when the membrane gets really positive, we open up voltage-gated calcium channels. Let me get my typer back here. Voltage-gated calcium channels. When I open up the voltage-gated calcium channels, a bunch of calcium rushes inside. And what happens in a neuron or in a hair cell when calcium comes inside of it? What do those cells do when a bunch of calcium comes in? Yeah, exactly. Calcium makes neurotransmitters spit out, or makes them leave. We release them. Remember, neurotransmitters can't even with calcium. So if calcium's coming in, neurotransmitters are spitting out. So when you're hearing a sound, when your hair cells are bumping the tectorial membrane and we're pushing in a bunch of potassium, which depolarized us, made us bring in a bunch of calcium, that's going to make us spit out a bunch of neurotransmitters. When you hear a sound, you spit out a bunch of neurotransmitters. That activates the vestibulocochlear nerve. We know we're hearing something. When you're done hearing something, though, when that sound that you just heard stops, how many neurotransmitters do we spit out at that point? When you've just finished hearing a sound, basically when those sound waves go into scala tympani. Yeah, at that point we have no neurotransmitters. No neurotransmitters. So we go from really activating the vestibulocochlear nerve to sending it no messages. That's the way your brain knows, okay, I'm done hearing that sound. I just heard it a whole bunch and now I'm not hearing it. That sound is gone. In general, when we're in between hearing things, if we're waiting to hear another sound, if you will, in normal circumstances, what's going on with our neurotransmitter release? If I'm just chilling out waiting. Yeah, this is going to be the time where I send out a few neurotransmitters. A few neurotransmitters. Yeah, like Monica mentioned, this is the slow and steady. The slow and steady. If you look back at that picture about the process of hearing, remember that we spit out just a few neurotransmitters because a few of the hairs on my hair cells have their gates pushed open. Just a few of them, not a lot of them, because we're just waiting for a sound. So that causes us to bring in a little bit of potassium, so bring in a little bit of calcium. We spit out a little bit of neurotransmitters. So when you're waiting, remember that we just kind of send little pings to the brain saying, hey, I haven't heard anything recently, but I'm still waiting, hopefully soon. When I hear something, I send all the messages to tell the brain. When I just finished hearing something, I send silence. The brain knows there's no sound. And then we go back to waiting. So it's a big circle game. We're waiting, we're waiting. Oh my gosh, we hear something. Silence. We're waiting, we're waiting. Here it is again. Loud noise, nothing. That's how the process of hearing works. It has to do with the number of neurotransmitters we're spitting out. When we talk about balance or equilibrium, it also has to do with the rate that we spit out neurotransmitters. When we talk about static equilibrium, Remember that this is the kind of balance that's relative to gravity. So you pulling forward or you pulling backwards, this is the kind of thing that static equilibrium detects. Theoretically, most of the time, you're holding your head upright. Usually your head is facing forward, it's not falling forwards or backwards. When your head is upright, what's going on with your neurotransmitters? A lot, a little, a few. What's going on when your head is upright? Yeah, this is the time again where we're doing the slow and steady thing. The slow and steady thing. So we're sending out a few messages just to let the brain know, hey, I'm paying attention. And right now we've got those here. Let's remind ourselves, what's the name of the little crystals that help us to know our head is upright? What's Dr. Ollis's favorite thing in static equilibrium? Yeah, those little guys called otoliths. That's my favorite. Yep. For my friends who weren't here when we did this discussion in class, we were talking about how they kind of look like little snowmen. So the frozen snowman, his name is Olaf, but we talked about how my daughter calls him Olaf, and I just refused to correct her. So when we're thinking about static equilibrium, we got our little Olafs, our little otoliths that are sitting on top of the macula. They're sitting on top of it, and they're putting a little bit of pressure on it. We spit out just a few messages. Your brain knows my head is upright. If your head starts to bend forward, what happens to my number of messages? They're going to get faster or slower when I build forward. Yeah, so when I'm bending forward, I send messages quickly. So more messages quickly. Oops, quickly. Your head starts to go forward. As you bend your head forward, those otoliths, those little Olafs, press on the hair cells, open up their mechanically gated potassium channels, which brings in a bunch of calcium. We spit out a ton of neurotransmitters, a bunch of messages. So when your head goes forward, we send a lot of messages. Your brain hears that and interprets that as I'm going forward. When we bend our head backwards, what's going on with those messages? What's happening when Olaf moves toward the back, those little otoliths? Yeah, so we don't actually spit out none, but we do spit out a lot fewer. So we start to close the gates. Yep, some of the gates. Just by the fact, though, that we've got stuff pressing on them, we will still always spit out a few, but it's a lot fewer than normal. Yeah, so when we talk about bending our head backwards, it's very few messages, or we're talking really slow. We activate that nerve a whole lot less when our head goes backwards. So when your head goes backwards, we're sending fewer messages. Remember I gave you guys the example with static equilibrium. This is how you fall asleep in class. If your head goes backwards in class, you're like totally passed out, right? The people in class who fall asleep with their head backwards are the ones who are really passed out. So very few messages going to the brain at all because they're totally passed out. When our head bends forward, it's an SOS. This is when you're first starting to fall asleep. So we send a bunch of messages trying to wake you up before you completely pass out. But all of us are alert, right? We're all looking forward. We're taking stuff in, slow and steady, sending out the right number of messages. To Nicole's question, she asked about static equilibrium being the one that you feel in an elevator. That's correct. Yeah, when you feel that jolt when the elevator starts going up or down, yes, that is feeling what's going on with static equilibrium. Absolutely. When we talk about dynamic equilibrium, the other word we said for dynamic equilibrium was rotational equilibrium. They're the same thing, rotational equilibrium or dynamic equilibrium. So this is all about whether you're spinning, whether you just stop spinning, what's going on with that. When we talk about you spinning, what's going on with the number of messages when you're spinning, when you're doing that ice skating turn, for example? Yeah, when you start spinning, we spit out a lot of messages. There's a lot of messages. We're activating that nerve really quickly. Let's remind ourselves of some of the words for dynamic equilibrium. What was the name of that bendy thing that sticks up, that goes kind of back and forth? I called it, said it kind of looked like a little tongue of fire. Yeah, the thing that's on top of my hair cells, here's my little hair cells down here. The thing that's on top of the hair cells, that's called the cupula. So instead of using otoliths, little crystals, when we talk about you rotating, what we're using to help you detect rotation is a flexible membrane called the cupula. When you start spinning, the fluid, the endolymph fluid inside your semicircular canals pushes on the cupula. It pushes on the cupula and pushes open all of its mechanically gated potassium channels, which means we open up the calcium channels, which means we spit out a whole bunch of messages. When you first start spinning, we spit out tons of messages for your body to know that we're spinning. When we stop spinning, what's going on with our messages? So the minute we stop doing that ice skating twirl and we're standing still, what happens to our messages when we've just stopped spinning? Yeah, the messages slow way down. So messages very slow. We've still got a few channels that are being pushed open, but most of them are being slammed shut, because now my little cupula, my bendy thing up here, is bending the opposite direction that it was bending before, pushing most of those gates shut. Normal circumstances, we are not usually spinning, just on occasion. When we are in normal circumstances and not rotating around, what's going on with my messages? How many messages do we spit out when we're just chilling out normally? Yeah, we're nervous about the question. We don't need to be nervous. When in doubt, just guess the normal amount of messages when you're doing the normal thing for your body. So when you're not spinning, we're doing the slow and steady thing again. So we're doing slow and steady, a few messages, just a kind of, again, a constant little ping. So when you're not spinning, your brain detects that we're not spinning. Your ears detect that. They send a few messages to the brain saying, we're waiting, not currently spinning, we're waiting for that. When we start spinning, we tell the brain that we just started. When we stop spinning, we slow the messages way down, so we're not sending hardly any messages until we get back to the normal rate, when our fluid is all settled and we're no longer doing that wobbly thing you do after you spin a whole bunch. Questions about neurotransmitters and these three processes here? The question is asking about ears popping on the airplane. When your ears pop on the airplane, that actually has to do with your middle ear. Your middle ear, that part we were talking about, that's normally supposed to be filled with air. There's air inside the middle ear. There's air outside the middle ear. When the pressure is different outside versus inside, like when an airplane is taking off, when you swallow, you're forcing air to get to the same pressure in your middle ear compared to your external ear. So the popping sound that you hear, that you feel, is when we're equalizing the pressure in your middle ear compared to the external ear. So it doesn't really have anything to do with the equilibrium as much as it has to do with the pressure outside and inside the middle ear. That's why if you've ever flown with a child who has an ear infection, it's real bad for them because an ear infection is, remember, is when the middle ear is filled with junk, and when we get the pressure different outside versus inside and they can't really equalize the pressure, that's why it hurts. So they tell you to chew on gum or to suck on something because it will help with the pressure that we can't swallow or force away because we have an ear infection. Yeah, so Gloria's asking what that has to do with. It's that thing that we talked about called the pharyngotympanic tube. That extra one, the pharyngotympanic tube. Yeah. Yeah, big long word. Don't blame you for not remembering that one. All right, one more quick thing that we did in groups. We did a little bit of predicting, and these were predictions, and I heard one of my groups mentioning that I asked you to predict at least one of these things in your lesson outline. So we're talking about the two chemical senses in the body, the sense of taste and the sense of smell. Can you help me in the chat? What are the technical names for taste and smell? What's their anatomy names for taste and smell? Yeah, so taste has the name gustation. When we talk about smell, the name of smell is olfaction. Remember, for our special senses, we've got to know the cranial nerves that do them. So olfaction is done by the olfactory nerve, cranial nerve number 1. Gustation is a little bit harder. We just have to memorize our gustation nerves. That's number 7 and number 9, facial and glossopharyngeal. So when we talk about the process of gustation, because it is a chemical sense, we said before group work that with chemical senses, you have to dissolve a chemical for us to be able to detect it. When you do gustation, when you do taste, what we dissolve our chemicals in is saliva. That's the ultimate purpose of your spit, is to dissolve what you're tasting. We have a normal amount of saliva, a normal amount of spit that we have in our mouth, but it's possible for us to have too much. If we had too much saliva or too much spit, what did we predict in our groups would happen if we had too much saliva? What's going to happen to your sense of taste? Yeah, so when we talk about the sense of taste, if I had too much saliva, our sense of taste would decrease. Sense of taste decreases. Yeah, so Nicole's mentioning we could dissolve those tastins too much. We'd have trouble getting those taste sensations down to the papillae. When we were doing the guided lesson, I actually talked to you about what happens when you have too much mucus. What happens with your sense of smell when there's too much mucus? Or let's put a different way. Yeah, so you can't smell is what we talked about. What was the condition that we talked about where you have too much mucus? What did we say you have if you've got too much mucus? What makes your body make too much mucus? Yeah, if we still have some kind of infection, right, or some kind of cold. Yeah, you could have coronavirus. I hope not. If we're making too much mucus, we are probably trying to blow our nose, get it out. We could have allergies. Let's go a little bit less serious, right? We could have allergies. When we have too much snot, we can't smell anymore. If I had too much spit, I couldn't taste anymore either. The idea is the same, and I know I heard one of my groups using this word. If I've got too much saliva, I dissolve my chemicals, but I end up diluting them. So if I've got too much saliva, when we're talking about taste, those chemicals are called tastants. So tastants get diluted. And if I dilute my tastants, they're not going to be as strong of a flavor. So flavor gets weaker. And if I have way too much saliva, my tastants may never get all the way down to my taste buds. Because like Nicole mentioned in the chat, when we're talking about the process of taste, we have to put those tastants have to get all the way down through our little holes on the tongue called taste pores, down to where my gustatory hair cells are found. So if I take my tastants and dilute them a whole bunch, they may never make it down to the hair cells, and I may never taste them. So if you have too much saliva, too much spit, your sense of taste is going to go down. That's because my tastants are being way too diluted. We're dropping them in way too much solution, and I'm not going to be able to taste them. What would happen to my sense of smell, or for that matter, we could say the same thing with my sense of taste? What would happen to my sense of smell if I didn't have enough mucus? What did we think might happen if we have too little mucus? Any ideas? Yeah, so Monica's correct that we wouldn't be able to smell either. So sense of smell would decrease. Why would your sense of smell decrease if we don't have enough mucus? Were we able to figure out why that might happen? Yeah, so when we're talking about a chemical sense, remember that we said anything that's a chemical sense, we have to dissolve the chemicals before we can detect them. If I don't have enough of my stuff to dissolve them in, then I'm not going to be able to dissolve them. And if they're not dissolved, my hair cells can't detect them. So if I have too little mucus, I would not dissolve my odorants, my things that help me smell. If I don't have enough mucus, I can't dissolve my odorants. And if I can't dissolve them, I can't detect them. So I can't detect odorants that aren't dissolved. Here's the big idea with chemical senses. We got problems on either end. If you've got too much liquid or too little liquid, it doesn't matter. Too much or too little, same problem. I still can't do my sense right. If we put too much of that liquid, we're diluting our chemicals too much. We're never going to be able to detect them. If I don't have enough of that liquid, I can't dissolve my chemicals. And remember, they have to be dissolved for me to be able to detect them. So with those chemical senses, very important that we know chemical senses require what we're detecting to be dissolved. How do we feel about these application questions here? Thumbs up, thumbs down. So I don't forget today, let me go ahead and give you your daily penguin. Monica's got a question, go for it.
So I was mentioning, maybe I overlooked or overheard, I don't know, but the vagus nerve, number 10, is that part of the sense of taste as well? I thought I saw it in the video.
Yeah, I believe that that one does also contribute to taste as well. I think that might be more of the throat tasting. But yeah, cranial nerve number 10, and let me consult my friend the Google here, just to confirm vagus nerve taste. Let's confirm. Yeah, so my first hit when I did a search for vagus nerve taste is that it has a minor role in tasting. The big ones that I want you to make sure you know are 7 and 9. Number 10 does play a role again in the upper part of your throat, or there's a little flappy thing that prevents food from going down your windpipe. We also do a little bit of tasting there too. So the vagus nerve would help out with those places. Focus primarily though on number 7 and number 9. Those are our big taste ones, 7 and 9. All right, in the time we have left, I know I got some questions about reflexes. We wanted to talk about reflexes. So let me pull up our pictures from lesson number 12 about reflexes, and we'll remind ourselves of the kind of things we need to do with the reflexes. So in class, we talked about 4 different reflexes. With those reflexes, let's make a list over here of what we need to know about the 4 that we talked about in class. So the first thing we need to know about each of the reflexes that we talked about in class is we need to know what their stimulus is, If you were to try to describe in easy words what the word stimulus means, can we think of an easy way to describe what a stimulus is? It is a little tricky to describe. Do we have any ideas? Okay, perfect. So what's causing us to do the reflex, or what it is we're feeling? I like that. So the stimulus is kind of what starts the reflex arc. So what starts the reflex. For each of our reflexes, we need to know what makes them happen. That's the first thing we need to know. The second thing we need to know about each of the 4 reflexes that we studied in class is we need to know if they are cranial or spinal. Cranial or spinal. When we talk about cranial versus spinal reflexes, what do these words tell us? Or what do these words mean for us when we're classifying a reflex this way? Cranial or spinal? Okay, so yeah, so we're talking about kind of where we're collecting information, right? Like spinal nerves versus cranial nerves, or in general, these 2 terms kind of tell us where we process information, we'll say. So the part of the body where we're going to do integration, the place where we figure out where to respond. When we talk about a cranial reflex, the part of the body that helps us know, or the part of the body that's going to figure out how we're going to respond is going to be somewhere like the brainstem, for example. Cranial, we're up by the head, a cranial reflex. Most of our reflexes in the body, though, are spinal reflexes. Not a trick question. When I talk about a spinal reflex, where are we processing that kind of information in a spinal reflex? Yeah, exactly. The spinal reflex, we're processing in the spinal cord. Remember I told you with our reflexes, anytime you see a spinal cord, in the picture of the reflex arc, that's a spinal reflex. 100% of the time, if you see a spinal cord, it's a spinal reflex. We're processing in the spinal cord. 100% of the time, if you don't see the spinal cord, so even if you have no idea what you're looking at, if you know it's not the spinal cord, that means it's a cranial reflex. So cranial reflexes and spinal reflexes, one of the ways we classify our reflexes based on where they're processing their information. Is it in the brainstem or is it somewhere in the spinal cord? Next thing we need to know about reflexes is if they are monosynaptic or polysynaptic. Monosynaptic or polysynaptic. When we talk about this way to classify reflexes, it's all about synapses. Synapses. Can you remind me in the chat, what is a synapse? Or what happens at a synapse? We're either frantically typing or very scared of synapses. Yeah, so a synapse is just a fancy word for where two neurons meet. It's the location, like we talked about in lesson number 10. My presynaptic neuron brings a message, and my postsynaptic neuron receives that message. When we talk about a reflex that is monosynaptic, how many synapses does a monosynaptic reflex have? Yeah, mono just means one synapse. If we have a monosynaptic reflex, we are going to have no interneuron. Monosynaptic reflexes have no interneurons, no processing neurons. Monosynaptic reflexes, we go straight from a sensory neuron that collects information to a motor neuron that makes things happen. Monosynaptic. Most of the reflexes in the body, though, are polysynaptic. Polysynaptic. What does that word polysynaptic mean? What does polysynaptic mean? Yeah, poly means multiple. Poly means many. So we're going to have at least two synapses. It means that we do have an interneuron. We're going to say yes, interneuron. There is one. There's no interneuron in a monosynaptic reflex. There is an interneuron, at least one interneuron in a polysynaptic reflex. So we need to know basically the number of synapses, the number of places that neurons share information. We need to know where we process the information. We need to know what it is that causes us to do this reflex. And the final thing that we need to know is which side or sides of the body respond in the reflex. If I talk about an ipsilateral reflex, what does ipsilateral mean? Yeah, ipsilateral is the same side, So if my sensory information comes in on the left side and my motor information goes out the left side, that's an ipsilateral reflex. They're on the same side. If I talk about a contralateral reflex, then what would contralateral mean? It's a contralateral reflex. Yeah, that's going to mean we're on the opposite side. Typically, with a contralateral reflex, we might actually see a response on both sides of the body. But what's important is information comes in on the left, and at least some information goes out on the right. If information goes out the opposite side of the spinal cord in response to what comes in, that's a contralateral reflex. While you're figuring out what to study for reflexes for the exam, we need to make sure for each of the 4 reflexes we talked about, you need to know these specific things about them. I will not give you a picture, so we just need to memorize, for example, that the stimulus for the patellar reflex is stretching. Remember, the patellar reflex, this is the one where we kick our doctor. The reason we kick our doctor is because we stretched our patellar tendon. We detect that stretching. The stimulus for the patellar reflex is stretching. When I look at the patellar reflex, I see a spinal cord. Because I see a spinal cord, that means the patellar reflex is a spinal reflex. So we need to memorize that the patellar reflex is a spinal reflex. When we talk about the patellar reflex, is it monosynaptic or polysynaptic? Do we remember? Yeah, the patellar reflex is a monosynaptic reflex, a monosynaptic reflex. We know that because when we look at it, there is one synapse. We go from the sensory neuron into the motor neuron. Monosynaptic reflex. There's no interneuron in this reflex. And finally, is the patellar reflex ipsilateral or contralateral? Ipsilateral or contralateral? Yeah, a couple of us are chiming in. We have information that comes in on this side and goes out the same side. This is an ipsilateral reflex. Yeah, so to Jacqueline's question, for the reflexes we talked about in class, we do need to have memorized this information about them. So go through and make yourself a list. Here, I'll type our list really fast here. Patellar reflex, well, here, I'll circle. Our stimulus is stretching. So on my list for the patellar reflex, my stimulus, I'm going to memorize, is stretching. The patellar reflex is a spinal reflex. It's a monosynaptic reflex, and it's an ipsilateral reflex. I need to have this information memorized for the patellar reflex. And remember how we were talking about how you can totally read the questions out loud or talk out loud? If you want to too, you can totally act out the patellar reflex. If that will help you at all to remember these 4 pieces of information, go for it. To help you remember that the patellar reflex, we're stretching. This is a spinal reflex. It's a monosynaptic reflex. It's an ipsilateral reflex. Let me look at my question here in the chat. So the question is, for this particular reflex, would we say pain or pressure as the stimulus? Okay, for other ones. Yeah, so for other ones, so let's look at some of our other ones to talk about our stimuli for that. When we talk about the flexor withdrawal reflex, the stimulus on this one is going to be pain. So the stimulus on the flexor withdrawal reflex, when we're looking at a list of options, this is the one where we touch a hot burner, for example. Pain is causing us to pull away. So pain on this one. When we're talking about the crossed extensor reflex, again, we would probably say that pain is what triggers this one as well. If pain is not an option, then we would say pressure. But in general, we're going to say pain for the crossed extensor reflex, as well as the flexor withdrawal reflex. When things are hurting us, it's causing us to respond. I can deal with some pressure. I can halfway step on a Lego and not trip this reflex. But if I step all the way on that Lego, I have too much pressure. That's going to hurt. So crossed extensor reflex and the flexor withdrawal reflex, for both of those, memorize your stimulus as pain. Pain is what makes those things happen. Let's talk about this one since it's up right now. We'll go back to the other one. When we talk about the crossed extensor reflex, we just said that our stimulus is pain. When we talk about the crossed extensor reflex, are we going to say that this one is cranial or spinal? Is this one cranial or spinal? Yep, this is going to be a spinal reflex, because there's that spinal cord, right? Spinal reflex. Are we going to say that this one is monosynaptic or polysynaptic? Monosynaptic or polysynaptic? Yep, this is definitely polysynaptic. In fact, this is the one that's the most polysynaptic of all of them, because check this out. Here comes my sensory information, that pain, comes into the spinal cord, and my sensory neuron branches to at least 3 different interneurons. So we synapse with 3 different interneurons that synapse with multiple different motor neurons. There are all kinds of synapses going on in this one. This is definitely a polysynaptic reflex. And Tierney's right. My last classification for this reflex, this would be considered a contralateral reflex. Contralateral. Contralateral reflex information came in over here. Not only does it go in on the same side, it also, or go out on the same side, it also goes out on the opposite side as well. And yeah, Nicole mentioned the name of this one's super helpful to give us that hint. When we talk about the crossed extensor reflex, we're crossing over to the opposite side of the spinal cord. So this was my one example of a contralateral reflex, and its name tells me that it's going to be. It's a crossed extensor reflex. So here's my classification here for the crossed extensor reflex, my one example of a contralateral reflex. Let's mention when we look at the blinking reflex, this one was my one example of which kind of reflex? What does this part of my picture show me? Yeah, the blinking reflex is my one example of a cranial reflex, a cranial reflex. So the blinking reflex, we do our processing in the brainstem, not in the spinal cord. When we talk about the blinking reflex, would we say that this one is monosynaptic or polysynaptic? Which synapse word are we going to use on this one? Yep, this is another polysynaptic reflex, another polysynaptic reflex. Is this one ipsilateral or contralateral? Can we tell? Yep, this is going to be another ipsilateral reflex. The way we can tell, by the way, see how I've got my sensory information coming in one side, motor information going out the same side. So it's an ipsilateral reflex. And when we talk about the stimulus on this one, this is going to be touch sensations. If anything touches your cornea, I mean, pain would do it too, but if anything touches your cornea, this is why your eyes start to water and blink when an eyelash falls in. That's thanks to the blinking reflex. So just stuff touching the cornea should trip this one. We don't have to get all the way to the pain for this one to fire. So stimulus, stimulus, touch. For the one other reflex that we didn't do together here, let's go back to it. Yeah, Ariel asked if air could cause this reflex too. Yeah, so if enough, like what the doctor's office, right? When they pump air into your eye when they're checking it, or the wind. Either of those, if we get enough air, it almost feels like something's touching it on your eye. So yeah, either of those things could trip this reflex too. So if something is touching, or if something puts enough pressure on your eye to make it feel like you're touching with the wind or with air, that would make you blink too. Absolutely. Here's that last reflex. We mentioned it. Flexor withdrawal reflex. What did we say the stimulus was on this one? Stimulus on the flexor withdrawal reflex. Yep, this is another one that is tripped by pain. Is this one cranial or spinal? What kind of reflex is the flexor withdrawal reflex? Yep, it's a spinal reflex. Monosynaptic or polysynaptic? What's going on with this one? This is another polysynaptic. Oops, spelled that wrong. And is this ipsilateral or contralateral? Ipsilateral or contralateral? Yeah, ipsilateral. So when you are studying reflexes for the exam, for these 4 that we talked about, make sure you have this information memorized for the 4 that we talked about. We also did a practice activity, remember, where I gave you a random reflex that you hadn't seen before, and I asked you to do the same kinds of things on it. So to use the clues in the picture to help you know, I wouldn't ask you the stimulus, I'm never going to make you predict that, but I will make you predict, is this cranial or spinal? I will make you predict, is it polysynaptic or monosynaptic? I will make you predict, is it ipsilateral or contralateral? Let me see if I happen to still have that activity in here. I'm betting I don't. So give me a moment. Let me try to pull it up. Yeah, so I used the model from lab. For my friends who were here for that group work, we used the lab model. Let me see if I can find that one so I can pull up that picture really fast. Not that day. Let's try this day. Okay, perfect. So let me upload. Actually, here, this will be faster if I can get this to work. Okay, I'm going to share my screen. I'm not going to be able to write, but it'll go faster. So let's share. My screen. Okay, so this is a picture of the model that we looked at in lab. Remember when we were talking about it in lab, we talked about things like the sensory neuron, the interneuron, the motor neuron. Anytime you look at a reflex, now that we've used some of those words to classify them, we can do the exact same thing. We can make these kinds of predictions just by looking at a picture. So this model from lab, when I look at it, I see a sensory neuron that's synapsing with an interneuron, that's synapsing with a motor neuron. Would I call this reflex from lab monosynaptic or polysynaptic? Yeah, this is going to be a polysynaptic reflex because I've got 1 and 2 synapses. We're polysynaptic. When I look at this model, does it tell me this is cranial or spinal? What kind of reflex do we have here? Yeah, this is an example of a spinal reflex because here's my spinal cord right here. I can see the spinal cord. That means it's a spinal reflex. And can I predict, is this ipsilateral or contralateral based on my picture? Yeah, so a few of us are voting in. This is ipsilateral because the sensory information comes in on this side and the motor information goes out the same side. If I only have involvement on one side of the spinal cord, that's an ipsilateral reflex. If we were looking at like that other one, where we also had motor information going out the other side, then we would have a contralateral reflex. But this one, we only send information in and out on the same side. That makes it an ipsilateral reflex. So if you want to study For the prediction side of reflexes that I'm going to make you do on the exam, just do a Google Images search, type in reflex arc, and it'll pull up a whole bunch of different pictures for you of reflexes in the body. Go through and do exactly what we just did. Count the number of synapses. If I just have one synapse, one place where things meet, it's a monosynaptic reflex. If I've got multiple places they meet, that's a polysynaptic reflex. Check to see if that reflex has a spinal cord in it. If there's a spinal cord in that picture, it's a spinal reflex. If not, it's a cranial reflex. And look at the side that information goes out and in. One side versus both sides. I promise the prediction questions are not going to be as scary as you're afraid that they are. If you can have these basic skills like we just used to interpret this picture here, you're in good shape. You should be all set. We are about out of time, but do we have any last minute questions? Tierney asked how many questions on the exam. I'm thinking it's in the ballpark of 50-ish. Some of them have more than one part, so it comes to 60 points. So expect to be answering or providing 60 facts, put it that way, since it's 60 points. Yeah, so the exam is open now. It has to be completed by Friday night at 11:59. So plan on getting it done today, tomorrow, or at the latest on Friday. I will be in front of my computer tomorrow from 9:30 to 11 for open office hours. That might be a good time to take it in case you have any issues. I'll be right here waiting to help you. Although remember, it's best if for some reason you get booted out, please contact Proctorio first right away because they can get you back into the exam. I cannot. So please contact Proctorio if you have any issues with taking it, and then get in touch with me too. If they can't solve your problem, then go ahead and get in touch with me. We will review for the final exam on Friday. So if you happen to have a chance to knock exam number 4 out before Friday morning's class, then you'll be ready to just start reviewing for that final. But we'll be here Friday at 9:30 to review for the final exam. Otherwise, we'll finish up our review next week. Yeah, so good luck to anyone taking it today and tomorrow. Like I said, I'll be available tomorrow morning if you have questions. Otherwise, best of luck to you, and I hope to see most of you back again on Friday for a review.